Welcome everybody to this session entitled Valve Choice, Shaping Index Procedures and Lifetime Patient Management, sponsored by Boston Scientific. My name is Tanja Rudolph from Germany, and I'm honored here to be surrounded by very well experienced colleagues. Won Kim from Germany as well, Claire Appleby, UK. We have Thomas Rück from Sweden, Michael Reardon from the US, and finally Fausto Castriota from Italy.
Exactly.
This is supposed to be an interactive session, so we are happy to take your questions. You can do it going to the mic, but we also have the possibility here via the app. And I think we hopefully will learn a lot about this device during the next 60 minutes. And I hand over to my co-chair, Juan, to introduce the first speaker.
Yeah, very happy to be here. Let's really do it interactively. If you have questions, comments, feel free. And happy to introduce the first presentation by Michael Reardon. Actually, no need to introduce you, Michael. You will talk about the Accurate IDE sub-analysis, and you know that the IDE data were more or less disappointing, and Michael, you will elaborate about the deeper dive on this topic. Thank you very much.
Great. Well, thank you for the introduction. As said, I'm Michael Reardon. I'm a cardiac surgeon from Houston and was the surgical PI in this trial. And today we're talking a little bit about update of this post hoc analysis we did of the trial itself. These are my conflicts of interest. As you remember, the trial was a randomized controlled trial of Accurate II against commercially available valves, which in the U.S. was the Sapien valve and the Evolut valve. They were randomized 1-to-1, 1,500 patients, about 1/3 Evolut, about 2/3 Sapien. We chose a non-inferiority margin of 8%, and the posterior median difference was 6.3%, but the 95% Bayesian confidence interval across that, so we did not meet non-inferiority. Now, it's an interesting trial. Raj Makkar was my co-PI on this. You can see at the very beginning, we were really ramping up quickly, and then we were hit by the worldwide pandemic of COVID, and it just slowed us down. And it took us almost 4 years to fill this trial with 1,500 patients, such that there was about 3 months between each individual Accurate neo implant per site. Now, if you look at the procedural characteristics, Accurate looked great procedurally. There was no real difference in correct positioning, valve migration, embolization, ectopic, deployment, conversion to open heart surgery, TAV and TAV, all very similar. They looked just the same. The only difference was there was more pre and post dilatation in the Accurate arm. And at 30 days, it also looked like this. It really matched the control valve. The problem was we got to the end, as you saw, and we missed our endpoint. And so we went back and said, well, why would this be? And the first thing we did was we sat down with some engineers from Boston, and we went back over all the arteriograms, and we found some that were underexpanded. And then after talking to the FDA, we went back and got an independent core lab to look at this. And so we wanted to have a comprehensive retrospective investigation to see what was going on here. And what we looked at was the angulation of the commercial posts. If they weren't straight, we would define those as non-expanded valves. And we know that valve underexpansion has the potential to compromise leaflet mechanics as well as impair valve hemodynamics. And so prosthetic deformation can result in restricted mobility and increase the thromboembolic risk. So what were the results? Well, we started off with 752 in the Accurate arm. There were a number that fell out for a variety of reasons. The most common is we didn't have procedural arteriograms. That left us with 624. And about 20%, a little over 20% of those were underexpanded, and a little less than 80% were expanded. Now, what we did is we defined these boxes around the valve, and we looked for the commercial post, and we drew a line through the post. If those lines crossed within these boxes, then they were defined as underexpanded. If they didn't, they were defined as truly expanded valves. If we look at the baseline echo, there's really only difference in the total volume of calcium, more common in valves that weren't fully expanded. The larger valves and the ones that unexpanded but didn't quite reach statistical significance, 0.5. So trended towards larger valves and statistically for more calcium. If we look at the procedural characteristics, there's no real difference in frequency of pre-dilatation, no difference in the size of the balloons, and no difference in the frequency of post-dilatation. And if we look at a multivariable analysis of the predictor of underexpansion, once again, the only thing that fell out was the level of calcification in these valves. If we look at the hemodynamics, whether we look at EOA or gradient, there's no difference at any time period. Interesting enough, we usually post-dilate because of a remaining gradient or PVL, and this was really the same across there, including PVL. No difference in PVL between underexpanded and fully expanded valves. However, if you look at the clinical outcomes, and if you look at the primary endpoint, which was death, stroke, or hospitalization, the red line is the underexpanded valves, the black dotted line is the expanded valve, and the blue line is the control valves. So there was a statistical difference between the underexpanded valve and control valve, no difference statistically between the expanded valves and the control valves. And then if we look at death and stroke, which is really something that relieve hospitalization, but just death and stroke, again, the statistical difference between the underexpanded valve and control, and really no difference between the fully expanded valve and control. So this led us to believe that if you could fully expand these valves, they really should have done as well as the control valve. We just weren't aware when we ran this trial of how to look at these valves. We were doing them in coplanar, not in RAO. Most of the underexpansion we see in an RAO or a cusp overlap. And when we put these valves on a pulse duplicator, what you see is that for expanded NEO2, there's really low velocities, there's laminar flow, and there's adequate washout of the sinuses. In the underexpanded valve, not only does it crimp the leaflet, but it causes turbulent flow, higher velocity, and reduced washout. A very plausible reason for platelet buildup and possible platelet embolization. And again, this is what it looks like. You look at the valve on the left, you see that the posts are not aligned, and just as importantly, you see that the waist is less than the height. Once you balloon this, you'll see the posts are aligned, and very importantly, the waist should be just as wide as the height of the valve. Now that we know this, it's impossible to unsee this, and when you do this valve, you should do it not only in a coplanar, but you should roll over and look at it in an REO view also. The impact of post-dilatation, if we looked at this, was that underexpanded valves undergoing post-dilatation, about half of them underexpanded improved and half of them didn't improve. And I don't really know if that's because we weren't expanding them enough, because we really weren't recognizing this. This is just what was done in the trial. If we look at the impact of learning curve, there's no impact on the learning curve. Didn't matter how many your site enrolled, didn't matter how many you did. But again, the most done by any one surgeon in this trial, I think, was like 15. So nobody had a lot of experience with this. And again, most sites are doing this once every 3 months. Very hard to build knowledge of how these valves should look if that's what you're doing. And this study really underscores the clinical relevance of optimal valve expansion. I think we all now start to agree that that applies to every single valve in the TAVR field. Underexpansion is a problem. There's opportunities that we identified for optimization of the procedural technique to mitigate against underexpansion. And the routine use of effective pre-dilatation is very important. A number of the balloons that were used in this were less than what we recommended, which was 1 millimeter less than the perimeter drive diameter. 2/3 of these were Edwards. Many of my Edwards sites don't pre-balloon with their Edwards, and they were told they had to do a pre-balloon, so they just ballooned it with something like they would with an Edwards, with a 18 balloon, and just moved on. So I think some of this was a lack of knowledge and following the IFU on our part. Post-dilatation should be performed when feasible to really improve expansion. If you look at the essentials that we need to remember, underexpansion was common, about 22% of the accurate NEOs in this, exhibiting frame underexpansion on final angiography. Calcification matters, higher leaflet and annular calcification burden predicted underexpansion, and that's consistent with this valve's slightly lower radial opening force. Remember, this is before prime when we changed the valve to get higher opening forces. The clinical significance of underexpanded frames carry a significantly higher risk of a primary endpoint of composite of all death, stroke, or hospitalization at 1 year. And the practical tool is a simple fluoroscopy can tell you if these valves are underexpanded. It's really easy to see, and it enables real-time identification and correction of this. And the broader message is achieving full symmetric expansion when safe appears to be important for optimal outcomes for accurate NEO2, and this is really true for all TAVR platforms that are out there. I'm stopping. I'll be happy to answer any questions.
So I think before we discuss your talk, I would like to ask Won Kim to give his presentation on European experience in light of the IDE trial, and then I think we're going to discuss the two presentations together.
Yeah, thank you. I just will continue with the European experience, and we'll have to try to reconcile the IDE trial outcomes that you reported on and the European outcomes. There are some points that are consistent and some that are different that we need to discuss, and no need to go deeper into the background. You already elaborated on the IDE trial outcomes and mid-frame underexpansion being likely a reason for adverse events occurring through 1 year. And so what we were astonished about is that European data, European experience, and you should be aware that we have more than 10, 12 years experience with this platform, had a learning curve from the Accurate Neo 1, 2, and Prime. And the European data that we saw were consistently showing non-inferiority. And this was across many different countries. Here you see a German analysis that we did in 3 high-volume centers, experience with both the Accurate platform and the Sapien Ultra. You can see primary endpoint at 1 year was similar in a matched cohort. And on the right-hand side, really excellent analysis by Andreas Rück. I think it's accepted for publication, presented at CRT, an emulation of what happened in IDE with all Swedish TAVI data showing after matching also no outcome between Accurate Neo 2 and Evolute or Sapien 3 platform. So this was really remarkable and drove us to dive deeper into what happened in the European cohort, and what we aimed at was to explore the rate and the clinical impact of mid-frame underexpansion. And Michael already showed you how this was identified looking at the box and looking at underexpansion here, especially in this area, and this is why we called it mid-frame underexpansion. Here you can see a very extreme example, and this is what it looks like on the bench, and we have some CT data that really look very similar. You can assume, you can imagine that this would impair both function and mid and long-term outcomes. And I think this is in contrast to what we knew, inflow underexpansion, and it's just an assumption. I would assume that due to the super underleaflet position, that this may have less impact on outcomes. So let's look at the study flowchart. Was Accurate patients that had angiograms in the 3-cusp view from 2 centers, and this was in a period of 3 years. We enrolled 604 patients, and this is what we were identifying after initial deployment. So this is step 2, and after step 2, we saw mid-frame underexpansion of in 24%. 3% was not evaluable, and around 3/4 of patients initially had no evidence of mid-frame underexpansion. So this was immediately after implantation. So, of course, we did post-dilatation in a number of patients, and we did post-dilatation in both groups, those that had no mid-frame underexpansion, and also in the group of patients that had mid-frame underexpansion. And we should keep in mind that at that time, we were not aware of what underexpansion looks like and its clinical implications. So this is what we already also learned due to the IDE trial. And the main reasons for post-dilatation were either PVL or increased gradients, or these extreme examples of inflow underexpansion. So this explains why we did post-dilatation also in those patients that presented without initial mid-frame underexpansion in around 100 cases, so 1/4. But also we did post-dilatation in those patients that presented with mid-frame underexpansion, again, not for the underexpansion itself, but for PVL or increased gradients. You can see that among those patients that received post-dilatation, and this is a little bit different to what we saw in the IDE, we can discuss later about the reasons for these differences. Here in our European cohort, in most cases that underwent post-dilatation, underexpansion could be mitigated in around 90%. So this resulted in a final assessment in a rate of underexpansion of 14% versus 86%. This was with a slightly different methodology used, and if we used the similar method as in the IDE, the rate of underexpansion was slightly lower with 10%. So let's look at the baseline characteristics. Some of you may say maybe those patients with underexpansion had more calcification or different characteristics, comorbidities. If you look at the baseline characteristics, no difference. Especially calcification was similar between the two groups. Also in terms of procedural aspects, there was no difference in predilatation, also other aspects. And what is very remarkable, I think, that immediate in-hospital outcomes were similar. So technical success was the same, device success, mean gradients, EOA, etc., no signal for more complication in this group. So what was different? What we found was that the rate of post-dilatation was different with 8% among those patients that had midframe underexpansion versus 34%, so a significant difference. There was also a signal in terms of balloon size. The balloon sizes were larger, and also a signal in terms of commissural alignment. At that time, we didn't do commissural alignment systematically. We just started. I know that in the IDE, commissural alignment was not employed. And what we also saw that a stroke already began to increase in hospital in those patients that had midframe underexpansion. So looking at the primary endpoint, and it was a combination of all-cause death, stroke, and rehospitalization at 1 year, so the same endpoints as in the IDE, you can see that there was clear segregation, and this was driven by more strokes occurring in the first 3 months, and then also all-cause mortality reaching a plateau after 12 months. So I told you that we had different methods to look at underexpansion, and there was also a gradual measurement of underexpansion, allowing us to measure it gradually. So we measured the distance between the bent posts, and measured delta post, and a higher number would indicate more deformation. And what we saw, and this would underline our concept, because this is only an association, and of course we cannot prove anything, but you see that there are different degrees of underexpansion, and we saw that with increasing degree of underexpansion, there was a very high correlation and a very robust dose-response relation with the primary endpoint. We also looked at predictors of initial midframe underexpansion, and again, initial midframe underexpansion was after initial deployment, step 2, before post-dilatation, and the only predictor of initial midframe underexpansion was, and this is what we would expect, the degree of calcification, and this is similar to what we saw in the IDE trial. Now, after taking into consideration post-dilatation, there was a difference. So the degree of calcification was not relevant anymore, but only the fact whether post-dilatation was performed or not. So post-dilatation, you can assume, initial frame underexpansion is related primarily to the degree of calcification. Everybody understands that. But obviously, if we perform post-dilatation, at least in the European cohort, we can fix underexpansion. So let's look at the efficacy and safety of post-dilatation. And again, it was like a blinded fashion, because at that time we didn't know what underexpansion looks like, and we didn't primarily address underexpansion. And this is the reason why among 140 patients with initial underexpansion, we only performed post-dilatation in around half of those patients, but we saw that in most cases where post-dilatation was performed, at least in the European cohort, underexpansion could be mitigated. And you see the effect also on the primary endpoint with a number needed to treat of only 4. So 4 post-dilatation performed reduced 1 event. On the other hand, you can see that performing post-dilatation, even in the absence of initial underexpansion, there was no downside on it, so no signal of more complications. I know that we cannot directly compare the two trials or the two studies, but of course there are differences in terms of age. Predilatation actually was not very much different, but if predilatation was performed, larger balloon sizes were used, and also the difference in terms of post-dilatation is not remarkable, but 5% is 5%. And what is very obvious is that balloon sizes were larger. So if post-dilatation was performed in more patients and with larger balloon sizes. Commissural alignment could play a role. It's only an assumption, but maybe implantation depth could also have contributed. It's only an assumption. So this is my personal explanation for the 11% difference in what we saw, and it's open to discussion. Here's a very illustrative case example that I really like to share because it underlines the problem. So this was a case that I proctored, and you can see that after initial deployment, there was still some residual leak. There was, you may appreciate, who can see that the stent posts are not parallelly aligned? Who sees it? Okay. Okay. And who thinks it's parallel? Just please, or you don't know. Okay, it's difficult. It took me a while until I really understood what to be looking at. And I suggested doing a post-dilatation, but the operator was hesitant because of the shallow position. And I suggested going to an en face view. And here you can see what it looked like, and you can see that there is really some indentation in this region. And this was the major driver to perform post-dilatation that you can see here. And after that, I think it's not a big difference, but I think it looks more circular in shape, and PVL was gone. And of course, we didn't achieve a perfect outcome, but if you look at the scale of different degrees of underexpansion, I think we achieved an improvement from very severe underexpansion to probably mild underexpansion, which may be sufficient already. So I would like to summarize European Accurate NEO2 data consistently showed similar outcomes to control groups. This was not only in Germany and in Sweden, but also in Italy and UK, so consistently across many European countries. And despite better outcomes in European cohorts, despite probably more aggressive pre-dilatation, more frequent post-dilatation, there was still a proportion of patients that presented with midframe underexpansion in a relevant proportion, I would say, 9.4% when using the similar method, but it was lower than in the IDE trial. And what we saw, and this was consistent to what we saw in the IDE trial, that midframe underexpansion was associated with worse outcome. But as Michael already mentioned, we can identify and address midframe underexpansion during the index procedure. And I think if it's required, post-dilatation effectively is able to mitigate underexpansion and may improve outcomes. So this is my personal conclusion and outlook, and I was confronted also with many questions. I think what we have to learn of this is that operators, and this is not only for the Accurate platform, but across all different TAVI platforms, need to be aware of the consequences of underexpansion and should be able to recognize it. So the question is, do we need a randomized study to prove the concept of underexpansion? It would be nice to have, but I think it's unrealistic. I think that we know that this concept of underexpansion is very familiar to us interventional cardiologists, and it's biologically plausible, and we know it from coronary stents. And I think that this dose-response relationship that I showed you is quite reassuring. So do we need more sophisticated imaging to diagnose underexpansion? And I don't think, it's my personal opinion, we do not need to rely exclusively on fluoro, which is difficult. You can try to obtain an en face view, but I think other imaging options, IVUS, eyes, etc., could be an alternative. Should we postulate all patients? Because this question comes frequently. Definitely no. I think postulatation is not necessary in all patients and should be only considered when we identify midframe underexpansion, of course, if you have increased gradients in PVL. And the last question, should we put patients with underexpansion that cannot be mitigated on anticoagulation? No data. If you ask me, maybe I would consider it on an individual basis. And with that, I'm open to questions. Thank you very much.
Yeah, thank you so much for this very insightful presentations. Until we will receive some questions from the audience, maybe I might ask Michael and just one short question. What is your takeaway now if you're now implanting an accurate valve. So do you assess the hemodynamic, or do you assess first the underexpansion and then go immediately for post-dilatation before you even bother about other aspects why a post-dilatation might be recommended?
Well, we do hemodynamics and echoes on everybody. I can't implant Accurate right now because of the U.S., but I do want to make one comment about the difference between Europe and the U.S. You have to look at how these trials in the U.S. were performed. The two original randomized trials, Edwards and Medtronic, we started with high and extreme risk. We had years to learn how to use the valve and improve the valve. Then we went to intermediate risk, and we had years to learn how to use the valve and improve the valve. And then we moved to low risk. And all of a sudden we come here and we take a valve that nobody in the U.S. has ever used and compare it against valves that we've been using for years. And we do it in the middle of COVID, where we're doing one Accurate every 3 months, and we're doing commercial valves every single week. And so there's real difference between how these trials were done and compared it, trying to compare it against other trials. It's not like we had an opportunity to learn this valve and then move to lower risk. And so I think that's the big difference. I think Europe had a chance to learn this valve before you started comparing it more head to head. And particularly doing this during the pandemic made it very hard because getting research done was exceedingly difficult, whereas commercial cases were still easy to do.
Yeah, I absolutely agree. So I can still implant a valve, and of course we first look at expansion. And if I have the feeling I have to post-dilate, and there are many criteria, obviously you can, of course I address inflow under expansion, but also if I see mid-frame under expansion, of course, and you can go to different angulations, depending also on the calcium load of the individual patient and how the valve behaves, how was pre-dial, post-dial, etc. But actually, yeah, if I have the feeling there is some under expansion, I immediately go for post-dilatation because I'm too lazy to put the catheter and do the pressure tracings. I don't know, Andreas, how do you do it? You have a very high post-dilatation, low threshold, right?
Yes, I mean, practically speaking, after you release the valve, obviously you have the fluoroscopy in front of you. So if you already then fulfill one of the criteria to post-dilate just by looking at the valve, you just do it, and then you can measure later, I guess, and do your echo, contrast injection, your pressure gradient, etc. And then most of the time you're done, because then you post-dilate with the size that you want to use for post-dilatation, then you know that you've done what is recommended. So that doesn't add much time to the procedure.
So it's definitely a more streamlined procedure as well. Okay, so there is a question.
It's more of a comment. It's my takeaway from Kim's work, if I may postulate. But what you showed with the comparison of the mid-frame expansion patients after post-dilatation, with only the mid-frame expansion being the only characteristic and calcification not becoming significant, I think is a telltale for us that pre-dilatation, especially when you're expecting heavy calcification or severely fibrotic valves, this is what we can take away from this analysis. This is my takeaway out of it. And second thing is, I think we should expand the indication for post-dilatation to not just PVL hemodynamics, but also mid-frame underexpansion, which is probably a particular problem because of this top-down implantation mechanism of the Accurate valve.
Yeah. So when we presented the ID, that's one of the things we pointed out is we've typically post-balloon for PVL or gradient, and that is not a guarantee that you're not under. So we presented this, we eventually do not stop at that. Look at the frame and make a decision.
Okay, so I think we have to move on, and it's my pleasure to introduce Claire Appleby to share with us a case presentation and a recorded case you have performed.
Okay, so thank you very much for the invitation. What I'm going to show you is a fairly standard case. This is an 80-year-old female. She was transferred over to us for urgent inpatient assessment, having been admitted some weeks earlier to her local hospital in decompensated heart failure. Her comorbidities included a previous CVA from which she'd made a fairly good functional recovery. She had COPD with emphysema evident on a CT. CKD3 with a baseline EGFR of about 53, hypertensive, type 2 diabetic, and long-standing iron deficiency anemia, which had been investigated. Her pre-morbid or pre-admission state, she was completely independent of all ADLs with a CAPS of 6, and she had at that stage, she was managing well in the community with a Rockwood of 3. Her baseline ECG showed normal sinus rhythm. There was no high-risk features. And on admission to her local hospital as investigation for a heart failure, her echo had shown severe aortic stenosis, Vmax of 4, with a peak gradient of 65, a mean of 41, the dimensionless index of 0.16. And this was actually in the context of a stroke volume index of 25, so a bit low flow. She had severe LV dysfunction. This was global, with an ejection fraction of around 35%. And her baseline showed hemoglobin of 87, creatinine improved up to 103, pro-BNP was over 1,500. Now, she'd had her CT at her referring hospital, and from an access point of view, I'm not sure how well this projects, but she had very small, generally small peripheral arteries, heavy plaque disease, mainly soft plaque, but some calcification around the aortoiliac junction, and it was worse on the right than the left, and the left was slightly larger. The other thing to mention, she'd had a short period on there at critical care and had had art lines in both sides and didn't have patent radials when she came over to us. So this was going to be a bifemoral approach. From an annular point of view, important to say that this was a diastolic phase scan from the hospital, so just to bear that in mind. But we had a perimeter of 656 millimetres and a derived diameter of 20.8. So this was a small annulus. The LVOT and the sinuses were also small as expected. Coronary heights were good, and I think as we move up and down that route, you can see that the calcium score on the valve was actually fairly low, around 1,000, mainly just on the leaflet tips, though there was actually quite a bit more calcium up at the STJ. So this was our procedural plan. The MDT obviously agreed that this would be a TAVI procedure, and we felt, given the small annular size, that this was in a female with low calcium, that this would be an ideal accurate case. We do all ours under local anaesthetic. She did have 25 mics of fentanyl at the start. We were using a left femoral with a 14 French eye sleeve. As I mentioned, bifemoral with a small sheath in the right. Safari wire, and we were pacing on the wire. Our pre-dilatation was a 20 sim. Remember, the derived annular diameter was 20.8. We were going to place an accurate and planned closure, 1 ProGlide and an angioseal, though in the event, I think we used 2. So that's the case presentation. Don't know whether you would like me to go straight on to the... now, this is a recorded case. I apologise. We had to do a voiceover because we had problems with the audio. So welcome to Liverpool Heart and Chest Hospital. We're a large cardiothoracic centre in the northwest of England. And the team today are shown here outside Cath Lab 1, our structural lab. Myself and my consultant colleagues, Shri and Joe. We have our 2 fellows, Mo and Ayush. And we're ably supported by Ange, Craig, and our nursing team, Chris, Aisha, and Nicola. And as with all of our cases, we start with ultrasound guided access. Now, and this is a bifemoral case because this lady has poor radial access. There we are in short axis view using a 12 o'clock puncture, and you can see as we swing into the long axis that we've got excellent placement over the centre of the femoral head, and there again in the short axis we see we're entering at 12 o'clock. So the team is satisfied with that we've got adequate access there. Flipping over onto the right femoral, which we're using for pigtail monitoring. Again, a good position on the anterior surface at the centre of the head. This is our setup shot, and we're in an eleocranial, we're PA cranial. The team did discuss coming a little bit more cranial, but splitting hairs really. Because we were concerned about access, we have taken a baseline angiogram, and you can see there is some plaque disease comorbidities there above the bifurcation, but it allowed very smooth transition with the eye sleeve, and they're just removing the dilator, but it was a very smooth transition there. You can see in the hemodynamics the patient nice and stable. The valve was quite quickly crossed, and we always flip over just to check our position in an RAO. We exchange for a pigtail. And at this stage, we will perform our invasive hemodynamics, and you can see here a gradient of about 40 millimetres of mercury. We're then going to switch to our, exchange out for our Safari, ensuring a good position of the Safari wire, and then go back to our pre-implant view. You can see the pigtails well positioned at the bottom of that coronary sinus. For our balloon pre-dilatation, it's important to get an adequate dilatation, and we're going here with a 20 millimetre SIM balloon. So under pacing, and you can see that's a really quite a good pre-dil with an adequate position on the balloon. And pressures recovered fairly quickly, though you can see that we've got some broadening of the QRS, so a little bit of bundle branch block there. So now we're, as you can see, we're transitioning through the pelvis with the valve. Again, fairly smooth through there. We usually take the arch in one, and then magging up over the annular plane, crossing through with the nose cone, and positioning our central marker about the top level of the pigtail. And it's in that position we're going to start looking at commissural alignment. And I think you can just see we're in a slight 2-to-1 position there. So Shri, our second operator, is rotating the catheter, the delivery catheter, away from him to try and obtain that 1-1-1 position in the three-cusp view. Flipping over now to the RAO caudal, and it looks like we've slightly over-compensated there, so we're going into 1-to-2, so bringing that back again until we're happier that we've got in the two-cusp view, we've got that 2-1 overlap. And we're going to then confirm that in our original three-cusp annular plane. And then starting to deploy. Now it's really important here that the wire is on the outer curvature, and it's seen nicely placed here with the Safari pigtail upward facing, and you're trying to position that central marker right down at the level of the bottom of the coronary cusp. Now if your pigtail's well placed, which it doesn't look, it looks like it's been dragged up by positioning of the advancing of the valve here. So if the pigtail's at the bottom, that'll serve as a great marker, but very important to ensure that you get that marker right at the bottom, and that as the first operator, you're always having a forward pressure, always forward when you're placing. Okay, so we're happy now, and we're going to start with 1A, so opening part A until you just see those upper crowns there expand, checking on fluoro that those crowns are above the leaflets. Looks like we've maybe migrated slightly down, so into a more ventricular position. So at this stage we're pushing on the wire, pulling the whole valve delivery back, and then resetting with a final forward position. And that looks a better position. So we're going to deploy 1B. So that first knob to a hard stop. There's the stabilising arches open. And there's a slight parallax on there, but that's a very satisfactory position. So removing the safety cap. I think the team are happy with that. And they're going to bring the pigtail back and make a final angiogram to ensure they're happy, and then deploy knob 2. And with the prime, that's a very fast movement. As you see there, opens well. And we've had detachment of the delivery catheter. So now it's very important to centralise that wire, and you do that by pulling the wire back so that you don't risk pulling the valve aortic to embolising the valve as you pull back. And you're reversing knob 1 and then knob 2, which you can do under screening. You want to ensure that the assembly catheter comes out all in one. So retrieving delivery catheter and resheathing there. And we're going to set up, we're just setting up now for an angiogram. And checking position. We flipped over into that RAO caudal where we see good expansion. And we're checking those, we're doing those 3 checks to make sure we're happy that the valve's well expanded. We can see the posts are parallel. The inflow and the outflow are the same width, and the valve is as tall as it is wide. And there's the angiogram showing a good position, 5 to 7 millimetres below the annular plane. And remember, the radial strength is going to be greatest at that annular plane with that sort of depth. So now I think we're ready to close. They've already deployed the ProGlides in this edited version. We still had some oozing, so 2 ProGlides. You'll remember there was some concern about access to begin with, hence upfront 2 ProGlides. With still some oozing, now we're finishing with a 6 French angioseal. Hemodynamics have remained excellent. We've still got a bit of a broad bundle branch, so this patient's going to be monitored. And the check angiogram, again, we haven't got any particular bleeding, some localised dissection, but I think given what the team started with, they're pretty happy with that result. So hopefully we've been able to demonstrate that with correct valve preparation, with a good pre-dilatation and checking throughout the procedure on adequate positioning, we've been able to achieve a great result, first time with excellent hemodynamics and very good immediate outcome for the patient. Thank you.
Thank you very much for this excellent case. I don't think we have too much time, but maybe any question from the audience? We have time, maybe time for one question. Otherwise, I think this was a perfect demonstration of optimized index procedure. You had a very good lesion preparation with the balloon size, 20 millimeter. You employed commercial alignment. You had a good positioning. I think what is especially important to look at what happens after initial step 1, so step 1A, and in most cases it will go upwards. In this case, it went downwards, and I think it's very important to correct for the position. And I think we saw no criteria to perform post-dilatation, so I think this was a very excellent index procedure outcome. Thank you very much. So yeah, Fausto, you will do the next part and showcase a 3D modeling on future treatment option through simulation, please.
Yes. Good afternoon to everyone. We have just seen a very nice, that's my potential conflict of interest. We have just seen a very nice straight case, step by step, how to implant this kind of valve with the perfect final result. So the clue of my very brief talk is to underline 2 points, 2 very, very important points. The lady was 8 years old, but as we know very well, we are treating young patients and low-risk patients, so we like to underline with the simulation that the guys from Boston made exactly on the case was just treated in Liverpool. 2 very important points. First of all, coronary reaccess. We know very well that the coronary are present as in a population of TAVI, but probably the most important point is this one. We know that especially when we are treating very young guys, the probability to have some necessary to cannulate again the coronary is not 0, is something between 3.5 to 7. And we know also that when we have an acute situation like an ST elevation myocardial infarction, sometimes the problem having a TAVI is something very, very important. For example, in this study, we recognize very well that the door to balloon time is much, much higher. I'm trying to have a mouse here, compared to the population without TAVR. And also, the failure of the TAVI is much, much higher. And also, the clinical outcomes, of course, if you're not able to open the artery, is much, much higher. So we have to consider that when you are treating young patients. And the second very important point is that when we are using supraannular TAVI, self-expandable TAVI, we know that even in a not acute situation, the reaccess could be difficult. Fortunately, we learn how to implant valve with a good orientation, and you notice in the procedure how the operator were very careful to have a good orientation during the procedure, because it's very, very important to have orientation for the coronary access. And we know very well, this is the reaccess 2 study, that even if you don't have a difference in terms of left coronary recannulation between the Evolute and the Accurate, we have some significant difference in the cannulation of the right. We know that's more difficult. Even this study was performed after the TAVI, so the majority of cases were treated to the femoral, that is normally easier compared to the radial approach. And we know very well that in the majority of cases, the problem was linked to the severe misalignment. So let's have a look at the case performed in Liverpool. This is the fluoroscopy. And this is the reconstruction with the simulation system. You see how clearly we can have a look at the right coronary, the perfect orientation of the valve, and we have also a nice orientation of the valve for the cannulation of the left. So with this model, we can simulate the access of the coronary in case we need on this lady to perform a coronary angiography in a very easy way. Even using the radial approach, we are able, through the stabilized arch, to go inside the right and inside the left. It's not just a draw; it's the real case we have just seen on the live in the box case. The second very important point is the redo TAV. As you know, this procedure probably in the next year will grow a lot. We have some data showing that probably the case of TAV in previous surgical biological valve is a kind of flat line, but it will have to face an increased number of patients with degenerative TAVI. And the TAV in TAV is something challenging. Of course, depend of the original anatomy, depend of the type of the valve you are going to treat, depend to many things. It's not the purpose of this talk to discuss about this, but the very important message is, in any case, once we are placing a valve inside another valve, we create a neoskirt. We have a kind of covered stent. So it's very, very important to have a clear idea of how to treat a degenerative valve. So let's do, for example, this is a case performed by All many years ago, was one of the first cases performed in a degenerative accurate valve. And it's very, very important to simulate and to understand. In this case was done with a CT scan, where to place a second valve. In this case, they decide to place a balloon expandable valve in a very low position to reduce the risk of coronary access difficulties. Of course, if you stay very low, you can have some overhanging of the leaflet, but normally with this kind of valve, you can have a very perfect position. Let's have a look if it's true. We simulate a position of a sapien tree in this Accurate Neo 23 valve. As you can see, we have a low position of the sapien, and we don't have overhang of the significant overhang of the leaflet. We can see again the right coronary, and we can see the left coronary. And if we simulate the cannulation again through the upper part and to the open arch, we are easily able to engage the right and to engage the left. So the final message is that even, especially when you are treating low-risk patients, to consider that we are implanting a valve that allows us these two things is very, very important. So coronary access, and in theory, to be prepared to a reduced TAVI in TAV. So that's the reason why in our center, in the very low-risk patient, one of our best choice is this kind of valve. Thank you for your attention.
Thank you so much for this really great presentation. I think it's really important when we talk about lifetime management to have a plan, what's next. And I think you showed really nicely here the access of the coronaries, and also a redo procedure can be nicely done. Are there any questions from your side?
I have one question. How did you simulate it? Was it a post-TAVR CT, or did you only use the fluoroscopic images?
That you have to ask the guys of Boston. But I think they just use the fluoro. Yeah, fluoroscopy. Yeah, talking about fluoroscopy, I would like to underline a very important point you mentioned. And also, Michael said that it's very important to see the fluoroscopy, because even when we are proctoring, the majority of people, because we are finishing our procedure in three-cusp view, they don't have the idea to go always on the right side. It's not very, sometimes the on-face view is very difficult to obtain with a huge caudal and so on. But just on the right side, you are able to see that valve is not completely expanded, like in a bicuspid case. So two projection, and you are able to recognize if you need the post-dilatation or not.
Okay, so I think we have to move on to our last speaker, Andreas Rück from Sweden. He's going to show us the first comprehensive data on the novel Prime device.
Yes, thank you very much for the invitation. I have shown most of the data yesterday at the TAVI Hotline 2 session. So this is then the first analysis that you will that has come out on the Prime platform. These are the 30-day results. These are my conflicts of interest. So we already talked about the design update, so I will skip that. But I'll just go to the registry. So this registry has an all-comers design, meaning that all consecutive accurate Prime patients at 12 European centers were entered into the registry. Exclusion criteria were only pure aortic regurgitation, no TAVI CT done, or active endocarditis. The study was investigator-initiated and supported by a grant by Boston Scientific. The clinical database was at Karolinska, and the imaging core lab was with Professor Solomon in Dublin, who has also analyzed lots of other data sets, including the IDE, for example. And here we'll see the 30-day echo and 30-day clinical outcomes. Study enrollment was very fast, so we started on the first day that this valve was commercially available in Europe in October last year, which coincided actually with quite well with the presentation of the IDE data in the US, so everybody, I think, was aware of the need for post-dilatation. And the last patient reached the 30-day follow-up just recently, so we're really happy that these 12 centers that you see here contributed and also sent in both clinical data and imaging data really quickly to the core lab and to the clinical database. Baseline data, quite unremarkable. Mean age 81 years, 50% female, Euroscore 4.4%. Of note, bicuspids 8% and valve-in-valve 2%. Both of those are not clinically indicated officially for the product, but were allowed in this registry. On the echo, quite unremarkable, 45 millimeters mean gradient on average, and good ejection fraction in most patients. Here you see the procedural data, 517 of these procedures in the registry, almost 100% femoral access, and as you've heard, predilatation is more or less mandated in this patient, so 99% were predilated. Post-dilatation, 50% in this cohort. And you see the sizing of the balloons here, so the average undersizing for predilatation, 1.6, for post-dilatation, 1.4, meaning in most cases, pre- and post-dilatation balloons were the same size. So this difference, or this undersizing, is less than in the IDE trial, for example. And you see the split between the different sizes of the prosthesis at the bottom. Here are the VARC3 defined procedural complications at exit from the procedure room. There's only 3 valvular-related complications, 1 need for second valve, 1 coronary obstruction, which could be fixed, and then valve embolization and conversion to surgery is the same patient. And then added to that, 4 patients fulfilled the criteria for vascular intervention, non-technical success. So at the exit of the procedure room, 98% technical success. And now the 30-day data. Device success, as VARC3 defines it, 96.4%. You already saw the 1.4% technical non-success. To that we add the mortality, 0.4% at 30 days, no reinterventions. And then the echocardiographic criteria with moderate PVL in 1.2%, and a high gradient being either 3 meters per second or a mean gradient of 21%. Clinical outcomes, 2.9% major stroke, or all stroke, sorry, at 30 days. Major vascular complication, 2.1%, and new pacemaker rate just short of 10%, 9.8%. No myocardial infarctions and no acute kidney injuries, grade 3. Echocardiogram at 30 days, calculated opening area, big, 2.6 square centimeters, low mean gradient of 7.2 millimeters of mercury, and you'll see the split between the different grades of PVL at the bottom in the bar graph. 78% non-trace, 18% mild, and only 1.2% moderate PVL. Then I put this table in. This one was not shown yesterday, so this is the split by valve size. Obviously, lower numbers per valve size, so especially for the 29 valve size, which is new. We can see here at the bottom, pacemaker rates differ a little bit by size, but there doesn't seem to be a consistent pattern. As expected, the mean gradient goes down by valve size, so the largest one has the lowest mean gradient, and the inverse is true for the opening area, the AVA, and we can't see any clear pattern on the moderate PVL, as you maybe calculate only 6 patients had a moderate PVL, so no statistics on that. So 29 seems to work as well as the other ones. Then if we put this registry into perspective with other similar data, first on the right, marked in orange, the Ocean TAVI registry on the self-expanding Evolute FX, similar size of a registry. Then in the middle in blue, the prior generation, the Accurate Neo2, a very similar registry, many of the centers being similar, and importantly, the same core lab analysis as this one. So differences, this prime cohort has the highest percentage of post-dilatations, 50% now. If that is the ideal number, I'm not completely sure, I can't say, but it seems to be at least give good results. You'll see here we had quite a high number of bicuspids, 8% as pointed out, moderate PVL, low here, mean gradient, low, stroke 30-day, I would say in the range of what you would expect, and very low mortality at 30 days. Pacemaker rate a little higher than in the prior generation, but still less than 10%. So in conclusion, the Accurate Prime was evaluated in 517 all-comers patients. We achieved high technical success and 30-day device success. We have excellent echo results with a moderate PVL of only 1% and a mean gradient of 7. This marks an improvement compared to the previous iteration of the device. And we will, from the same registry later, show longer follow-up and also frame expansion data. Thank you.
Yeah, thank you very much for these for this excellent presentation. Is there any question from the panel? What do you think about the data? Are you surprised, or is this what you expected?
We are happy. Happy. Definitely. So the nice thing of this valve that is funny, because everyone that is using regularly knows very well, instead of data, papers and so on, that works very well. So the reason why we are using this valve every day, and especially as I mentioned in young guys with a long expectancy of life, because their access is very easy, not too much metal, valve in valve easy, so why not? Pacemaker rate very low. So that's the message, and these data are in that direction. So 10% even with large valve is nothing compared to the other self-expandable valves. So I'm happy.
I think it points out one of the problems we have with the U.S. trial. I mean, remember Partner 2A with SAPIEN XT? If they had done SAPIEN XT all the way through and hadn't learned on earlier trials, they would have failed because it wasn't a good valve. You know, it didn't have a chance to go through generations and get to where we are now with the Prime. And I do think that was problematic. That's an issue that we have with the FDA. Because I think if we could rerun this with Prime, after people had a little learning experience with this, we'd do just as well, if not better, than commercial valves.
So, Andreas, I mean, these outcomes are very compelling, right? Very high technical success, very high device success, high procedural safety. The only thing is that the pacemaker rate went up a little bit compared to what we've seen in NEO 2. I think there is a high variability in what we see across different studies. Do you have any explanation or outlook on this? I mean, we are still in a one-digit region, right?
Yeah, we just made it to the single digit, that's correct. I thought about it for a while and discussed it with some other colleagues. One change in the implantation practice, which might be a bit subtle, but it is that we have this better marker for parallax now, which means at my center, and I think most centers, we look at it in every case, and what it does is that if you have a significant parallax, you need to push the valve down 2-3 millimeters. So I would just assume, without having the data on it yet, that it makes the average implantation depth a little lower than it was before. So that might be one reason. Then there's also the stronger stent, of course.
I think you guys are ballooning more aggressively. You know, if you look back at the Reprise trial when I ran with Ted Feldman, we went back at 6 months, and half the pacemakers we put in weren't being used at 6 months. And I think if you do the same thing here, you're going to have, some of these people had some early conduction defects because of aggressive ballooning, that if you could have waited a week or two, like we do in surgery, it would have gotten better. So it'd be really interesting to go back at 6 months and do pacemaker dependency studies. I guarantee you half of them aren't needed.
Okay. If there are no further questions, I will be happy to conclude. Thank you very much. So, there's only one slide, don't worry. I think we are in time. And thank you very much for the panel, excellent presentations. We have seen a deep dive discussion in what happened in the IDE on the European perspective. We have seen a very excellent case presentation of how to do an optimized index procedure. And I think Fausto, very sophisticated illustration of taking into consideration lifetime management, coronary access, and redo TAVI. And Andreas, I think you showed compelling outcomes with the new Prime platform. And this is my personal take-home message. IDE data were disappointing, period. But nothing to add, no. I think what we've seen is that European data show good outcomes. This is consistent of the Accurate platform. This is similar to comparators. And I think I want to underline, and this is very excellent what Andreas showed in the Sweetheart analysis. I think it became obvious that it is really crucial to recognize underexpansion, irrespective of the platform, and to see that this is a prognostically relevant finding. And I think this contributes to the overall field of TAVI. Underexpansion represents a challenge It is common. We are very familiar with the concept of underexpansion in intervention cardiology. But I think, at least in the European data, we showed that overwhelmingly this can be addressed. And the early prime data are reassuring and demonstrate that the higher radial force of the Accurate Prime in conjunction with an optimized index procedure can lead to favorable outcomes. Thank you very much for your attendance, for your discussions and contributions, and I wish you a very successful conference. Bye-bye.